Good evening. I'm Dennis Shelby with the Service Members and Veterans Initiative, the American Psychoanalytic Association, and we want to welcome you to the next edition of our ongoing series on war-related trauma from a psychoanalytic perspective. Tonight is, I think, going to be a very informative evening. We have two recent doctoral students who are going to be presenting their dissertation research. They were both graduates of the Military Veterans Specialization at the Institute for Clinical Social Work, and I just happened to be their dissertation chairs, so I'm a little bit biased. But first up, I think you can see on your screens we've got Bobbie Davis and Michael Miller. Bobbie Davis is going to go first. A little bit about Bobbie. She's currently in private practice and is an adjunct professor at Austin Peay State University in Clarksville, Tennessee. Bobbie previously served as Director of Clinical Services, Cumberland Hall Psychiatric Hospital in Hopkinsville, Kentucky, providing clinical supervision program design for the children and adolescent program, and designed the trauma program for PTSD for military inpatient programming while overseeing clinical services for all inpatient services. She's also served as a Department of Social Work, BACH, FAP, Fort Campbell, Kentucky, and FBCH, DBH, Fort Belvoir, Virginia. She's provided treatment, case management, individual therapy, group therapy, children, adolescent, and couples therapy in relation to the domestic violence. She served on SARB and SART Commanders Committee to treat active duty military members who are victims of sexual abuse on Fort Campbell. She's also provided individual and family therapy to soldiers and their dependents to aid in combat readiness, to include risk management, psychosocial assessments, and interventions needed for psychological disorders. She's developed and implemented the social group for adolescents on the autism spectrum. And she's also provided therapy to soldiers and their dependents to aid in combat readiness, risk management, emergency psych on-call, to evaluate high-risk patients, serve in the project improvement for decreasing no-shows for the Department of Behavioral Health, and PI consultations. And Bobbie will receive her PhD formally next month from the Institute for Clinical Social Work. And she's also got, over the years, has received some pretty beefy awards. 2013 Recognition for Service, ACE Award, Culture of Excellence for Outstanding Performance and Teamwork. 2013, the Bronze Award for 5 years of service in the government of the United States of America. 2011, she was Employee of the Year for the Department of Defense. In 2008, Employee of the Year, Blanchfield Army Community Hospital, Fort Campbell, Kentucky. So, and she had done most of that before she got her doctorate. So the other thing is Bobbie is legally blind, and it's easier if I read her slides and she will be here commenting. And what usually works the best for us all is to, if you have a question, go ahead and put it in the chat feature. And you can see that at the bottom of your screen if you run your cursor. Put it in that chat feature. It'll be there waiting for us. When Bobbie finishes, we'll have a few minutes for any questions and answers. And then we'll go on to Michael. But first, we're going to get going with Bobbie. Bobbie's study was entitled An Exploratory Study of Soldiers Who Feel Broken Post-Combat. And we put her email address right up there at the beginning and the end of the slideshow in case you want to contact her. So we're going to run through the study, and Bobbie will be there. Bobbie and Michael and I are used to, it sounds like we're interrupting, but we're usually just finishing each other's thoughts. So if we start talking that way, just give us a break. We've been at this for 7-8 years. Bobbie's interest in the topic. She first heard the term in her work with soldiers at Fort Campbell, Kentucky. Soldiers created and used the term broken to characterize their psychological condition as a result of combat experiences. However, it had never been described in full, and none of the guys that used the term broken met the full criteria for PTSD. Her interest was in understanding in depth the impact of combat experience was having on their lives. This chart lays out just who all participated in the study. Bobbie, do you have anything to say about the chart?
There was 15 participants. They ranged from specialist to captain. Age range was in their 20s to the latest, or the oldest was a 50-year-old male. All of them were males. I had one African American and one Native American. The majority of them had multiple marriages. We had one who was never married and one who was never divorced. So that would be the main statistics on demographics that was pertinent.
And how many deployments?
All of them had more than 2.
Okay. So in approaching this exploration of what folks meant when they said they were broken, Bobbie used grounded theory from Corbin and Strauss. She interviewed her folks in an open-ended way to ascertain the dimensions of what they felt goes into the meaning of broken. She conducted 1 screening interview and 2 45-minute interviews spaced out over time. The 4th interview was member checking to have participants look for accuracy and to see if any deeper data could be gleaned from their reactions to reading her results. Now, one of the things we emphasize at ICSW in qualitative research is talking about the process with the participants. And what Bobbie discovered over time was that there was a definite process to all the interviews. The first interview, the participants were guarded, and they really limited the information they provided. And the interview felt kind of rushed through the 3rd question. What was the 3rd question, Bobbie? You know?
The 3rd question was about what they thought the command, if the command had impact on their feeling of being broken.
Okay. In the 2nd interview, the soldier would open up, and the depth of the stories were profound, and the stories went way beyond what questions were asked, and Bobbie let them tell the story they wanted to tell. And also, as far as process, a form of disavowal was observed, right, and a kind of back and forth of talking, relating, and then distancing to kind of ground and reorient themselves, and then to go back. Now,
and that happened throughout all of the interviews except the screening interview. The disavow kind of continued through the 2nd and 3rd interview, as well as when I did the member checking interview. The members also showed that disavow, splitting off that affect and trying not to show that they were tearing up, those kinds of things.
All right, so when you say disavow, you were noticing people to try to keep the affect at bay while they talk. Okay.
Yes.
Now, one of the ways we organize data in grounded theory is into categories and properties. And these next few slides will be the categories and the properties. So category 1 was the event. And the properties were, which one do I talk about? The whole thing was bad, and I'm a killer. Anything you want to fill in on that first category, Bobbie?
what I found throughout that category specifically was more where there was a ton of disavow seen when they talked about I'm a killer, and they would jump back and forth talking about the emotions related to this. They tended to pull back when they would feel that anger and aggression. And just feeling like they had been absolutely changed from who they knew they were.
Okay. Category 2, feeling profoundly changed. The properties were numb, not feeling whole. There was a comparison of self-ideals with pre and post-combat. A feeling that others didn't see me the same. Afraid of myself, and not feeling normal.
Mm-hmm.
Want to add anything to that, Bobbie?
No, I think the profoundly changed is a lot of where the guys talked about this is where they thought maybe they had PTSD because they felt like it met part of their criteria from what the therapists and stuff would ask them. But then they wouldn't meet the full criteria with feeling like they were feeling like they were not able to continue, not able to move on, and like their world was over. They just felt like they were not the same person, but couldn't figure out why.
Okay. Category 3, survivor guilt. And Bobbie's properties were holds memories for other soldiers, the story, it is my fault, it should have been me, it keeps building up, and handling death. Anything you want to add to that?
I'm only going to add to the story. The story tended to be what they perceived happened to the soldier that was injured or had died. And the story was told from a third-party perspective of what happened to that person, not so much how they took the experience in.
Okay. But survivor guilt was big enough to have its own category.
Yes.
Okay. Category 4, command support, and the properties were not listening, don't understand, being let down, trusting with safety, and causing loss. Anything you want to fill in?
No, I think that's pretty self-explanatory. No.
All right, but clearly command and support was central to their experience to the point it deserved its own category.
Yes, and how they would argue about they didn't feel the command did this to them, but then would talk about stories how they did feel the command was part of it.
Okay.
That was very strong throughout as they would talk about the command. Like there was a conflict on I'm supposed to respect my command, care for my command, and trust my command, but I didn't. And so there was a major ideal conflict there that just psychic conflict that caused them to just keep talking about it, but kept saying, no, it's not what caused me to be broken.
All right, so they were holding both sides at the same time, holding on to
Correct.
the idealization, but a feeling that something had gotten ruptured with their command.
Correct.
Okay. Category 5, relationship distress. Profound feeling that the wife and family pose a threat, that they will not understand the things I've done, that I'm better off being alone, push away family, that life post-combat can feel pretty petty. And this feeling of that worrying about stupid things when I've actually faced death. You want to fill that in a bit?
I think we see this a lot, and it presents itself as a lot of chaos around the trauma. I think that the soldiers broke this down very well in the research to be able to talk about the difference between the wife, between the relationships with friends, and how they viewed their world once they came back. They were able to break this down in a very clear way throughout the process.
Okay.
I think we see it a lot in therapy as well, working with the soldiers. So.
Okay. Category 6 is not heard. Properties where Army and VA therapists are not listening, that the therapists stick to structured manual therapy, that the therapist and the family can't really handle it. It's kind of worrisome. Feeling only understood by other military people who have deployed, and only understood by people in the same MOS. You want to add to that, Bobbie?
This category, I think, is the reason why I felt the difference between the first face-to-face interview and the second face-to-face interview. That trust and that belief that other people can't handle the story, I think, is where most of these properties came forth. There's a fear, one of their own feelings about what they're going to be able to experience, and that's part of why we were seeing the disavow during the research. And then the fear that the other person is going to be impacted by that, and then they're not going to be understood. Okay. So, okay.
All right. So, one of the ways to approach writing up, qualitative research from Corbin and Strauss's perspective, and what we've kind of developed at ICSW, is to kind of, on one hand, we present categories and finding and properties, but then we hone in on what we call findings, themes, or aspects of the experience that really stood out. So finding 1 is that numbness results in withdrawal from relationships and social engagement. And Bobbie elaborates that numbness was described throughout the interviews, with participants giving insight into how the deployments caused a mental and emotional shutdown and/or multiple separations within the self. It's a very powerful concept, separations within the self. And the participants described this phenomenon as a disabling component which caused their self to change in such a way that their families took notice. Any additional thoughts on that, Bobbie?
The terminology the soldiers like to use is to turn it off. And as we broke this research down in that category of numbness, they talked a lot about the turning off, that they didn't know how to turn it back on in regarding their feelings, and that the families will even talk about and tell them that they're not the same. They don't have any emotional expression. They're not compassionate. They're not engaged in the family. It was a very profound finding within what all the guys talked about.
Okay. Finding 2, experiencing death, witnessing death or injuries of people close to them, and realizing that they could get killed at any time results in lasting psychological changes. The participants described a shift in the way they experienced the harsh reality of death. They moved from a realization that death can occur to the recognition that they are going to die, that it felt inevitable that they were going to die, and then they end up getting out of the deployment, ending up back here after having that feeling that I'm next. Is that what you're saying, Bobbie?
Yes.
Okay.
Yes, and that they're not understanding why they did not pass. And I think that kind of goes more into the survivor guilt, but trying to comprehend death and understanding death and seeing death changes their perspective and not knowing if it's their turn or not.
Okay. But once that shift from the land of the living to the land of dying has occurred, it doesn't go back easily?
No.
Okay.
I don't know if it does go back from what they've talked about.
From my experience, it doesn't fully go back, I would have to say.
Yeah.
Idealization of command is promoted and drilled into soldiers during training. The idealization of command is destined to be ruptured during the chaos of war due to variability in command skill and experience, and any pre-existing deficits in idealization are bound to be repeated in the unpredictable nature of war. Any thoughts on that, Bobbie?
I think it's a very important to understand that the command is also in war. It's bound to disrupt. It's bound to have a conflict with how they view the command as the command's making decisions and as the command's decisions are not understood, as well as the command leadership skills may not fulfill their expectations and their needs. So when that occurs, the soldiers have a lot of disruption on how do I follow this person and face death if I don't feel like I can trust you. Okay. So there's a ton of disruption, which then disrupts how they feel that they should be as a soldier because they're supposed to model after their command.
Does it also increase a sense of vulnerability?
It does. The vulnerability and the fear of if I don't feel like my command knows what they're doing, we're destined to face that death. We're not likely to come out of this. And there's a fear there and a vulnerability there, but they still follow that command.
Okay. Finding 4, survival guilt is bad news. The participants described ongoing guilt over their survival and ongoing idealization of the deceased and an identification with the deceased. Any thoughts on that?
The person who is passed or who is injured is held up on a pedestal, whether they needed to be or not. And that's a hard thing to say. The soldiers struggled with that. They would be talking about the soldier that passed or the soldier that was injured and talking about how much that soldier was honored, even though they would tell stories about that soldier was not meeting the standards that he was supposed to be meeting. No. And on the other side, if they were a highly respected soldier, that they want to live up to that and hold that person even higher on a pedestal.
Okay. And I think it says something about our theories of the role of survivor guilt in war-related distress, that we basically had to turn to the Holocaust literature to find what people's thoughts on survivor guilt. There's like none in the war literature, but it's there in the Holocaust literature. And I think that says something that maybe that's been neglected.
Right.
Finding 5, physically broken, mentally broken, and emotionally broken. The participants stated that feeling broken is comprised of 3 aspects: physically broken, mentally broken, and emotionally broken. These were further explained as a confluence of events where experience of death and disappointment come together and alter their perception of who they are. Right. Any thoughts on that, Bobbie?
The soldiers would talk about their brokenness in those 3 categories. Most of them would say, I'm either physically or emotionally broken. They really wouldn't talk much about the mentally, but they would explain what the mental broken was. And that would be that category of PTSD that they would say, I don't feel like I meet PTSD criteria. So they would describe those 3 areas and how that as those 3 would come together, form that feeling of brokenness. But without all three there, they said they didn't feel broken.
Okay, but I think you're making an important point that you can still feel pretty miserable and not meet criteria for PTSD.
Correct.
Is that?
And I think that's what the soldiers were conveying in the research, is that, you know, the criteria that's out there that they question about is not what they're feeling, even though they're feeling broken.
Okay.
That they're not feeling that they have this PTSD criteria met, that they're going to not function for the rest of their life, but they feel broken and don't know how to fix it.
Were they told by providers they had PTSD, any of these folks?
Some of them were.
Okay.
Some of them were. I don't think I had that statistic written up.
Off
the top of my head, I think it was about 5 or 6 of them that said they had, the therapist or provider at the VA said they met criteria.
Were any of these folks on get a disability?
Yes.
For PTSD,
Yeah.
or for something else?
Most of them was for physical. I did have 2 that had PTSD and physical.
Okay.
For their medical discharges.
All right. And one of the things you can do with grounded theory is, you know, in its original iteration, the goal of grounded theory was to create a substantive theory about the experience. And Bobbie went ahead and did this. And she kind of put a 5-step process together. That phase 1, see death and horrific injuries or face their own death. Phase 2, they move into a place where they do not care if they live or die. Phase 3 is risk-taking or taking things into their own hands. In phase 4, relationships start to dissolve. And these are primary love relationships, or these are
relationship, whether that's command, comrades, family, friendships, just relationship in general.
okay.
Intimate relationships is the way I would phrase it, but
Okay. And phase 5, the mind changes. Is that when this feeling of brokenness starts to take over?
yes, that when that self-ideal switches.
Okay.
Switches to that feeling of brokenness, that I'm not that top soldier that I thought I was.
All right. Clinical implications. The participants indicated that the idea of focusing merely on a discrete event is complicated because the problem is multifaceted. However, the study indicates that further assistance from the therapist is needed to allow the soldier to open up and be allowed to process the ways in which the discrete event has impacted other parts of his or her life, such as family, spouse, friendships, and command. The importance of focusing on the disruption in the family or spousal relationship can help to improve the support system and self-ideal found through the family and the spouse. As the therapist focuses on the impact over all deployments or the impact of the self-identification of being broken, the soldier has the opportunity to discuss the multifaceted components of the self-ideal and to process the effects that deployment has had on his or her life. The command relationship has a significant impact on the way in which the soldier processes the injuries and deaths of fellow soldiers and how the mission was approached. The data indicate that soldiers have difficulty placing the blame on the command. However, they have trust in the decisions and will follow the orders they are given. This disruption of questioning the leadership causes an internal process in which they question themselves and take blame for the incident. The study data echoes controversies in the war trauma literature involving the tension between events, the separation between family, and increased dependence on command and comrades in arms. Death is difficult to comprehend and impacts individuals differently. There are multiple approaches that look at how to process bereavement and feelings of loss, guilt, and shame. However, the participants struggle to use these models due to the level of pain they feel and the meaning that the death has on who that person was, as well as how it impacts how they have taken this person in as a self-ideal. Again, the findings echo the complexity of survivor guilt as explicated in the literature on survivor guilt. Anything you want to add, Bobbie?
No, I think as we talked about when we went through the categories, I think we kind of touched on those as I spoke about the categories. So,
okay.
No,
Disappointment and command is an important psychological event that ultimately leaves the soldier feeling more vulnerable in a threatening environment. Exploring this in the session can be filled with projections and displacement that need to be worked through to locate the client's distorted idea. This is a very interesting point. Can you talk about that some more, Bobbie?
I didn't hear what it said. I'm sorry.
Exploring this session can be filled with projections and displacements that need to be worked through to locate the client's distorted ideal.
Right. This is part of the projections that we see where they may be saying that the therapist doesn't understand you or doesn't understand the story, maybe projecting it out onto the command. You will even see that they project it out on what the war was even about, before they'll talk about the disruption within themselves and how it's impacted them and impacted the way that they see themselves. So the projection is pretty profound on putting it out really with a lot of aggression. They were pretty mad as they talked about those pieces to try to separate it from themselves.
Okay. The data also indicate the importance of disappointment and disruptions in primary spousal and family relationships adds to a deep sense of disorganization and a lack of anchoring to a psychological center.
Right.
Thoughts on that, Bobbie? You're packing a lot into these bullet points here. They're pretty rich.
I know. I sometimes don't know how to sum it up smaller.
Yeah.
In that bullet point, it's commenting on about how without the family feeling like the family is understanding them, that goes back to that other category. Without the family feeling like they're a part of it, understanding it, feeling like they can open up to their families, they lose that anchor and start to feel even more disrupted and more lost.
Okay. So I'm going to leave this contact information up in case you want to talk to Bobbie after the presentation. Any questions for Bobbie? From our good friend Norman Camp, who's the co-chair of the Service Members Veterans Initiative. Thought, if survivor guilt is burdensome, thoughts of being broken might bring some measure of relief, even if denied. Any study of disappointment. Okay, let's stick with that one. Norman, Bobbie, why don't you want to play with Norman's thought on that?
May I understand the question again? The way I understood it is that survivor guilt with the thought that I am broken might help them to understand the survivor guilt? Is the way they understood the question?
Well, I think Mike is, are you saying, Mike, that feeling broken might be used defensively to deal with survivor guilt. Is that what you're saying? Yes, I got it right. Okay. What do you think about that one, Bobbie?
I think that it could be considered as a defense. Looking at what my soldiers referred to, I think the brokenness more so came from an understanding that I'm not where I was, and feeling bad that they'd lost the person that had passed, that they were holding up on that pedestal that I referred to earlier. I think that the defensiveness of being broken, I don't know if the soldiers would agree with that. I think it would be more of a feeling of, I'm not seen like I used to be seen by others, and I don't feel like I'm the same as I used to be. I think in regards to the survivor guilt, that the brokenness is that I've lost a part of me in that ideal that I had in that person I lost.
Okay. Norman also said, any study of disappointment in the nation's sustained affirmation, celebration of their excesses and sacrifices? I mean, how do these guys react to the media attention, and did that come out in the interviews at all?
They taught, I had one specific soldier that when you asked that question came up, he talked about awards and how his awards did not mean anything because of the way that the command handled stuff. And that people would get awards for doing kind of crazy things in deployment, but not for things that they did that were heroic. He had talked about running back in to save somebody and get them out of the line of fire because he got wounded, but he wasn't, the soldier he ran into had not died. He ran in to grab him and brought him out, and he felt that was heroic and should have received an award for that. However, the command did not see it that way. They thought that more as risk taking and doing things that he shouldn't have done and not going by protocol. Where he said he would see a lot of people getting awards for things that were not considered heroic. So, and then they come back and they see the media. I think they get a lot, they talked a lot about the offensiveness of putting pictures on like YouTube. I had another soldier talking about that, how they would put scenes about what was happening in Afghanistan and Iraq and would put that on YouTube. And there was so much things that he read that the other people were writing that really offended him, because he said that they don't understand what it is like to be there.
Okay. Any other questions from folks that are out and about? No, we got a few more minutes. Mike, if no one's going to ask us questions, Mike, did you have any thoughts or questions for Bobbie?
Can you hear me?
Yes.
So Bobbie, what was it like for you as you were interviewing all of these participants? Did anything strike you? Did anything come up for you?
It was very different sitting as a researcher versus sitting as a therapist. I could feel myself fighting the temptation to slip into taking my countertransference and helping them process through it versus listening to the story. It did feel like I got a lot more information sitting back and not interjecting. So I found it hard but I also found it very enriching, would be the word I can say right now. I think there was more times I almost cried with them. I mean, it was pretty, there were moments that, you know, we had to shut the interview down while they stepped out, gathered themselves, and came back. And a lot of them said this was the first time they've told the story to anybody. So, and that struck me in a therapist way of, you know, what's going on that they're not feeling comfortable to go talk, you know. So that, I guess, encouraged me more to make sure I'm doing that when I do therapy with people, to make sure that they're feeling more comfortable to talk when I would hear that kind of stuff from the research. So I don't know if that answered your question, Mike.
Yes, it did. It was just a great answer. Yeah, that was amazing. Thank you.
We've got another question here. I recognize, is it Trigva Trosper? I think you've been on a number of these. It's got a good comment. The research tackles the elephant in the room. Is the military didn't have a clear mission statement as to why we were fighting. Therefore, the command couldn't articulate the mission statement through the standard operation order the soldiers are used to from their training. The command did let the soldiers down, and this needs to be explored more. Thoughts?
I agree, and I think that's part of what Colonel Yarvis was referring to about further research that we need to do.
Are you talking about your hearing?
Yeah.
Do you remember what Jeff said?
He said we needed to do further research in that area of combat command impact on the soldiers. And I mean, I know the military towards the year I was leaving in 2015, there was a lot of stuff being done for readiness of soldiers, but not so much around command leadership and being able to convey what the purpose is.
Okay.
And I think that makes a major difference for the soldiers, you know, and that's a lot of what they talked about with the command, is that they didn't really understand why we are doing this mission right now. What's the purpose of this mission? I remember one specific soldier talking about how he felt like we should do this a different way, and told the command how he thought it should be done. The command said, we're still doing it this way. This was the mission. This is the way we're ordered to do it. So they pushed forward and lost a lot of people. Would it have been different? We really don't know in hindsight, but that soldier felt it would be. And that confuses them as they look towards their leadership.
Okay. Well, it keeps reminding me of, you know, the Fairbairn's idea about the handing over of dependency to command, and, you know, the psychological need for command to be idealizable, clear, orderly, as well as kind of moving into more of a self-psychology framework, that the coherence that comes from idealization and the regulation that comes from idealization, and how those can go kapooey if an idealization is ruptured.
Yeah. Maybe
too fancy, but you know, it's my job to try and think this way. Any more? Mike and Bobbie are used to me doing this to them. Any other questions before we look at Mike's research? Last chance. Mike, you want to grill them anymore before we move on?
No, I'm good.
I was meant Mike Camp.
Oh, sorry.
Mike comes up with good questions. Well, looks like we're getting another one while Mike's thinking of another question here. Why isn't treatment, this is from Trigva again, why isn't treatment addressing grief? What is the real difference between grieving over a loved one or a significant other not in war versus war? Soldiers need to go through the stages of grief. Bobbie, Mike?
I absolutely agree. I know that in cognitive processing therapy is a model that the VA had come up with. There is a piece of bereavement in session 2 that they tackle, but most of the time they say, if you have this issue, we will separate out from the group or separate out from this session, and we will work on it. But it's really material you need to read when you're at home. And that's how they teach that in the training that I went to, was we don't really handle it. We kind of just give it to them to work through.
Right.
I don't know why they do that.
No. I think I think, you know, we're picking it up that I think grief and loss and survivor guilt gets lost in all the PTSD, work through the memories stuff that tends to dominate. And the whole issue of survivor guilt in itself indicates a grieving process that hasn't been worked through, in my opinion. And I do think it's a missing piece.
So Dennis, in all the years I worked at the VA and all the experiences I've had of treating veterans with post-traumatic stress disorder, I used to be a hospice social worker years ago. That was a bedrock of treatment that I made sure that I included. I did not use the evidence-based psychotherapies from the VA.
Right.
I just chose not to use those for various reasons, but that was a bedrock of the work that I did, because it's absolutely fundamental for them to work through the meaning they ascribe to those different losses, to the loss of self, to the loss of friends, to the loss of et cetera, et cetera, et cetera. It is so profound and so ubiquitous that it, in my humble opinion, in order for these folks to get better, to recover on some type of a level, to heal, I guess is a better word, they have to work through the grieving process.
You know, my other thought on that is that, and I talk about this when I'm presenting a lot, that we're used to thinking of complicated grief as turning into morbid depression. But what I've seen is complicated grief turning into what looks like a behavior disorder. And that once you start addressing the losses, that you start seeing what looks like a behavior disorder just settle down.
Right.
So I think it can go both ways, and it can be disguised. And I think a lot of clinicians somewhere in shrink school learned that complicated grief leads to depression, not that it can lead to dysregulation and behavioral disorders and drug and alcohol abuse, but it certainly can, in my experience.
Looks like
And
norming.
I think that,
Oh, sorry. Go ahead.
I think that's part of why they veer from it in the manualized therapy, because that's going to take you off from doing the work in the manualized therapy to treat the trauma, because the grief and loss is going to take some time to work through with that person, and then come back and try to get this done in 12 sessions. So I think it's always seems like there's a time constraint.
Mm-hmm.
I never followed that rule. So I would pull out and work on the grief and loss, because we're not going to get any further.
Well,
I think it comes down to the philosophy of the evidence-based psychotherapies. And Bobbie, what you said I thought was excellent, because the philosophy is in 12 sessions to try to ameliorate symptoms, and there's no integration, then of course that's a quick fix. Problem is they come back 3 to 6 months later because it's not integrated. And that was part of the research that I discovered through my own dissertation. But, you know, they're standing in front of you, and now's the time for integration. So you bring up a great point.
In case you didn't notice, we have 2 VA DOD rule breakers on tonight. So it's a joke
I
because
break the rules until after I got my DoD award.
it's a joke because when I interviewed folks for the program, I would always find a way to ask them if they were willing to break the rules because it was best for the client. And most everybody said yes. Norman, one last comment. We're going to go into Mike, and it's a good point that ties back that the failure of political leadership must trickle down through military leadership to lead to failure, and failure at the level of the traumatized soldier. It's a good point.
Mm-hmm.
Mm-hmm.
That goes back to Fairbairn as well.
Yep. I think that's what those of us that study the war trauma literature, we see the same things kind of becoming, coming back and forth, and very old ideas still very handy. In this day and age, we don't need to run to a consultant and get our new whistles and bells and manualized therapy going again.
Mm-hmm.
Okay, I'm going to get Mike's stuff up.
Great job, Bobbie. Thank you.
Why don't you guys
Mike.
entertain folks some more while I get this set up.
So Dennis, I hid my video, but I don't know that it's up. I can't find where to bring it up.
I can see you just fine.
Oh, good thing I wasn't picking my nose.
It's a very good thing.
Okay.
Mike, if it helps any, Mike, I can't see any of you, so you're good.
Pardon me. I do have a cold, so I'm periodically blowing my nose, as you probably all have seen already.
Hold on just a second. So, Michael Miller is a licensed clinical social worker, received his BS in psychology from the University of Utah, Salt Lake City, his Master's of Social Science Administration from Case Western Reserve University, Mandel School of Applied Social Sciences in Cleveland, and his doctorate in clinical social work from the Institute of Clinical Social Work in Chicago. Dr. Miller has worked in many different capacities as a psychiatric social worker, including child protective services, home care and hospice, and as a mental health clinical supervisor for an outpatient drug and alcohol agency. He also worked for the Veterans Administration in White City, Oregon, the Southern Oregon Rehabilitation Center and clinics, in multiple departments treating homeless veterans with serious mental illness and veterans with war-related PTSD. Currently, Dr. Miller works for Valley Family Practice, an independent primary healthcare clinic, as an integrated behavioral therapist consultant, and he's been practicing for nearly 20 years and lives in Medford, Oregon. So, take it away, Mike.
Well, I was wondering if we can get the slides on the first page.
It is on my screen. It is.
On your screen, it is. It's on slide number 4 on mine.
Well,
okay.
Is it on your? Is that right now?
Right. Yes.
Well, on mine it says it's your title page.
Okay. All right.
Let me try it this way.
Okay.
Mm-hmm.
I do have a copy of the slides in front of me, so if you just want to, I can kind of, probably, I'm sure I can follow you that way too, Dennis.
Yep. Like
Oh, there it is. There it is. It's totally correct now.
Okay.
So the title of my dissertation, Experiences of VA Therapists Treating OIF, OIF, OND Veterans. It just went off, Dennis, with combat PTSD.
Hold on. I'm having some trouble here. I think I figured out what I was doing, what it didn't like.
Okay.
How's that?
That looks great. Thanks. So I'm not sure the audience I'm speaking to. I don't know if everybody knows what OIF, or excuse me, OEF, OIF, OND means. So I'm just going to just quickly define that. So OEF is Operation Enduring Freedom, used for the war that began in Afghanistan in 2001. OIF is Operation Iraqi Freedom, the name of the war that began in Iraq in 2003, and OND is Operation New Dawn, which was the new operational name for the war in Iraq, which was announced in September 2010 to reflect the reduction of the U.S. troops under the Obama administration. And
keep going.
Okay, so the research question is, what are the experiences of VA mental health clinicians as they treat these veterans who served in Iraq and Afghanistan diagnosed with war-related PTSD? The reason I chose this question for a dissertation research is it comes out of my own experience of working with and supervising many social workers, those who were trying to get their clinical social work license, and those who had already had the license and had been practicing in the VA for quite a while. I noticed in terms of engaging in supervision with them that with some of them, when they would treat trauma, PTSD trauma with the veterans that they served, the room began spinning for many of them, but it didn't spin for all of them. And that kind of got me wondering, why does it spin for some? Truly, what are their experiences like as they sit and treat these folks? And what kind of an impact does it have on them? It also comes out of my own experience of treating them. Certainly, I've had the room spin myself. And taking the time to analyze that and look at that was very, very helpful in my own supervision. And so I decided to go ahead and to see what I can find. And that's the reason I chose this as the research question. So the type of study and the data collection is a qualitative study, grounded theory, methodology, again, as outlined by Strauss and Corbin in 2008. The data was collected from 2 separate interviews. The initial, and there were 17 participants. The initial interview was approximately 45 minutes in length, followed by another 45-minute interview. And it was audio taped and transcribed. Memos and field notes were written extensively throughout the interviewing data collection process. The sample, so the final number of participants was 17, and adult men and women who are VA mental health professionals who have experience treating OEF, OAF, OND combat veterans. In order to participate in the study, they had to have been treating veterans for 2 years. And the subjects recruited from 2 facilities in the Pacific Northwest, the VA Rehabilitation Center. 14 participants came from that locale. And the local vet center, there were 3 participants from that. So I was able to get participants from the rehabilitation VA center as well as from the local vet center. So there were 7 female and 10 male, and 16 Caucasian and 1 Samoan. And by discipline, 9 of them were LCSWs, 4 female and 5 male. Licensed psychologists, there were 4, 1 female and 3 male. Licensed professional counselors, 2, 1 female and 1 male. 1 psychiatrist and 1 psychiatric RN. And their ages ranged from 32 to 67. The average age was 49. Years worked for the VA was 2 to 25 years, and the average was 6. And there were 3 male veterans in the study that participated, and 1 active duty member at the time. So at the time that the study was done, the VA mental health clinicians at this specific facility were under the following guidelines. A lot of this has changed. Took me 4 years to write it and to do it, so we're talking about 5 years ago. 6 years ago. The majority of the participants treat veterans from all war eras who have combat-related PTSD. They do not pick and choose which veteran they will treat who meets the criteria for PTSD treatment. The VA mandates that only those veterans with combat-related PTSD can be treated. However, most of the participants treat other veterans with non-combat PTSD as well. They have enormous caseloads, and participants in the study do not have a formal program of clinical support, supervision, consultation on the local level. That last one has since changed. So what emerged? There were 7 categories or chapters with their variations that kind of emerged. And the 7 chapters are Entering the Fray, Chapter 2, OEF, OAF, O&D veterans are different. Chapter 3, Challenge to the Work. Chapter 4, Relive Trauma. Chapter 5, Practice Wisdom. Chapter 6, Different Person Now. And then the last chapter is, let me find it here. So the last chapter is New Ideas for Old Problems. So with the category map, Entering the Fray, so that was the main category. And then the properties, traumas that paved the way, families of veterans, interest in trauma, and I found the VA. So just quickly, briefly, so traumas that paved the way, the majority of these participants actually had traumas in their lives that helped to define their choice of entering the various professions that they chose, from psychiatry to social work, licensed professional counselors, et cetera, et cetera. And then families of veterans, almost all of them, I think there was only 2 participants that did not, but the rest all had families of veterans. They grew up with veterans. They grew up with veteran issues. They grew up with the veteran culture. They had, many of their families were from the Vietnam era. Many of them had PTSD themselves. So they were familiar, and they grew up within the family culture of veterans. Interest in trauma. Many of them developed an interest in trauma in various ways. Some was through their own trauma work that they did. Others, it was through watching their loved ones and what their loved ones experience and their family members experience, and things like that. And then the last property down there, I found the VA documents through the interviews how each of them came to work in the VA, and the different paths and the different ways in which that happened for them. So then we go to OEF, OAF, O&D veterans are different. Well, the main thing they said, the first property, they were tough to treat. This is a tough very tough population to treat. They also were very clear about, from their clinical experiences working with them, the characteristics that influence the treatment process and the toll that the physiological trauma had upon them, the individual behavioral characteristics as well, and the affective or emotional characteristics, and the childhood traumas. Many of them presented with personality disorders, but as soon as as Dennis was saying later, as soon as they started working through and integrating certain things, a lot of times those behavioral characteristics calm down. And then also how their childhood traumas impacted them as they were treating these folks, and how there was a level of mistrust right across from the board. And also that they are kids. Many of them are very, very young, and how treating this population had such an impact on these therapists that they're very different now, as well as not only the therapists but also the veterans that they interviewed. They were kids when they came in, very, very damaged kids as they left, in terms of older adolescents for a lot of them. The next chapter, challenge to the work, the properties keeping them, the bureaucracy, and the therapist's lens. Keeping them, how do we keep them in treatment? That was a big challenge for most of them. How do we hook them into treatment? How do we keep them? How do we keep the momentum going? How do we keep them from falling out of treatment? And the other thing is the bureaucracy of the VA. The bureaucracy often is very clear, at least back then. This is how you will treat them, and you won't have any type of variation. And most of the therapists, most of them went against those guidelines and followed their own conscience and did not stick to the evidence-based psychotherapies. And the therapist lens, looking at the way in which they have practiced for years or have been practicing for a few years, but the therapist lens in terms of the particular ways in which they look at and define treatment for themselves and the experiences that gave them. So that was a very rich chapter. Relive Trauma. This was probably the most, certainly the most interesting and the most emotionally driven chapter of the dissertation. There's stories that are hard for them to hear, and they were able to also identify the specific themes of those stories. Every therapist was able to do that. Many of them, it's when they heard about children that were killed, civilians, the intensity of the death and the loss of other former friends and other people in their troops and platoons and so on and so forth that they were close to, and just the horrors of war. Taking it home, many of them took it home. Many of them had nightmares. Several of them have very much an over-identification with the stories, the trauma stories of the veterans that they served, and like they would take them home. One participant in particular went to a movie and saw some blowing up things happening on screen, and she couldn't handle it. She had to get up. She had a flashback of a veteran. Interesting that she said she had a flashback of a veteran experience of a veteran she was currently treating, and the context physically and emotionally was there in front of her on the screen. She got nauseated and had to leave. She's never had an experience like that before, did not have a traumatic childhood. And then checking out as they're hearing a lot of these horrific stories in the room. Many of them said how they just kind of glossed over. They checked out. Some of them were so overcome with what they were hearing, what they were experiencing, they just kind of checked out. Certainly not everybody, but the majority of them did. And then the stories that stick, again, the specific themes that I went through, those were the stories that stuck for a lot of them. So practice wisdom. This was probably the longest chapter in the dissertation. Advice. What advice would you give to beginning trauma therapists? And there was so much, it just went for pages in terms of the transcription of the interviews. And then teaching them about the basics of how to conduct and do trauma therapy oriented work. The body and body states, how therapists should really understand that connection between the body and the person's body states, and how with PTSD and anxiety, these people don't stay within their bodies. They're elsewhere. They're in their mind. They are not connected to or connected to their body, and that a trauma therapist truly needs to understand that dynamic. Hope, that there is hope, that the therapist has to have hope, and that if the therapist doesn't have hope, the therapist should not be treating the veteran. That doesn't mean that it's a pathological hope. It's a hope that they have hope in the process, hope that what they're doing with this person will lead them somewhere. And then advice for new therapists, again, giving all kinds of advice on how to take care of oneself and so on and so forth. What I did and what I do now, many of them started, and what they did in the beginning didn't work as a trauma therapist. And over time, they learned what did and did not work for their particular style, and specifically what did and did not work as they were treating this population. And then the last one, every one of them said, being aware of my own stuff along that theme, being truly aware of their countertransference issues going on and what's coming up in the room for them, and how important that is to the work. Then trauma work wisdom. This is, again, pearls of wisdom that they've gleaned from years of trauma work, and that each veteran is not the same. You can't just make the assumption that because this person has PTSD and has experienced comrades being blown up, or has seen or accidentally killed a child or other civilians purposely or not, that each veteran feels and experiences it the same, because they don't. Military sexual trauma. Also explaining the differences with military sexual trauma, how devastating that is for the veterans that experience that those comrades and others and folks that they trust to save their lives are the ones that became the perpetrator and did what they did to them, and then how they have to sit and fight next to them as they're engaging the enemy, and the incredible dynamics and complexity of not only experiencing PTSD, but also that other added layer as well, was very, very interesting as the participants explained it from their perspective. Band-Aids talked specifically about the evidence-based psychotherapies, the two that Bobbie had talked about in her study, that they were supposed to be using, and how they were just Band-Aids, that several of them in the very beginning would absolutely launch in, do the manualized therapies, and then what would happen is that it would be a revolving door for these folks, because there's really not much of integration. It helps some, but for the majority of them, the symptoms came back. They would be back in their office sometimes as early as 3 to 6 months later. So they had to figure out a way that, you know what, we got to prepare these folks for the evidence-based psychotherapy. So we'll just spend time with them and talk with them and begin the process of integration. And a lot of times they made the clinical determination not to go through with any of the evidence-based psychotherapies. Heroes, the continuum. What I got from this in terms of interviewing the participants, the trauma therapists, and that they got from talking to the veterans, that the majority of them don't like to be called a hero. And what does that really mean? And it's kind of a romanticized term, and for many it's very offensive. And that the veterans let them know, and that the majority of the veterans that they treated did not see themselves as a hero. They saw themselves as doing a job. How to survive. And then how to survive is, how does the trauma therapist survive? How do you survive day in and day out hearing this? Many of them said, I wish that you know, I could kind of pick my trauma load here so that it wasn't so heavy. Others said, I wish I had more support from leadership at my particular, or at that particular VA, because wish I could, you know, do other clinical work instead of just spending every day, day in and day out, doing the same trauma work over and over individually and in groups. So that was a very interesting part of the study that came out. But the majority of them said the work is rewarding, how the work has changed them fundamentally changed them, and that they were able to develop more compassion, understanding, and things of that nature. It was interesting that I found some research at the University of New Mexico of some researchers there several years ago who researched this whole construct of vicarious resilience. So part of the study, of course, was about vicarious traumatization and the definitions and things of that, and burnout and secondary PTSD and all these different constructs. But what was interesting was that many of them exhibited this concept of vicarious resilience through hearing these incredible trauma stories and experiences from the veterans they served, and how it strengthened them, which totally supports the research that came out of the University of New Mexico. And then different person now, this was a very, very interesting chapter in terms of the deeper understanding of judgments as biases and boundaries within themselves, within these trauma therapists, how they gained greater knowledge into themselves, into the process, into human suffering, in terms of where the suffering comes from for them. And that as they went on and as they began to get to know themselves and feel more comfortable with the work as the years went on, for a lot of them, they felt more comfortable, competent, and compassionate. And all the various insights that they gleaned through the years of doing this kind of work also created a very new point of view for them. That how complex trauma and human suffering and the human condition is. And that when two people kind of come into the room, it truly is a co-creation. I did a theoretical model with Robert Stoller's intersubjective systems theory, the idea that when the clinician and the client or veteran comes into the room, it's a co-creation of meaning. And many of them actually talked about that, not in those terms, but certainly talked about that as a construct. And then the last chapter, new ideas for old patterns. The way it is now, well, the way it was back then was that there was no official program for clinical supervision. You wanted clinical supervision, you had to seek out people that you trusted, people that you could talk with, and who would have the time to sit down with you to discuss some pretty complex cases. It sounds crazy, but that's how it was. The idea in leadership there back then was that you're an LCSW. You should pretty much know everything, and that's exactly word for word what these trauma clinicians said. They felt that because they received their LCSW, that they're expected to know everything, and that the idea that if they have to take something to supervision, they are considered weak, and so on and so forth. They didn't feel safe discussing this with a lot of the supervisors. Those were their exact words. And that's where it comes in. Where's the support? A lot of times at that facility, all of the various different agencies and departments were siloed. And so, excuse me. So even within their own department, they would be in the PTSD clinic, but they would sit for hours in their own office and hardly have any type of interaction except once a week when they had a staff meeting. So there was this very compartmentalized, solitary, confined feeling with these folks and others that I interviewed throughout the facility who came up with the same phenomenon. Show no mercy. Many of them said when they tried to explain in staff meetings how they were feeling and the vulnerabilities they were feeling as they were treating these folks, many of them were shamed, openly shamed by supervisors and others. And again, I don't think this is just a solitary experience at one VA. Then the question was, if you could develop support at this facility as well as a new program for clinical supervision, what would it look like? So that's where that property came in, what it could look like. And the essentials that were needed, and that they had support, there was no judgment, people coming in, a very safe environment, and understanding the concepts of transference, countertransference, understanding the vulnerabilities that everybody experiences as they treat these folks, that we're not robotic, we're human beings with feelings, and that at times we can and often get overwhelmed, et cetera, et cetera. So they came up with all these different ideas. How do we do it? Having the Zen facilitator, somebody who's very balanced and understands what's going on. Having very necessary discussions of support and recognizing burnout and supporting these clinicians in that way. Being able to really feel what's going on and being able to really say that within clinical supervision without fear of being looked at as weak, et cetera, and that they need more training. That just because you have an LCSW, we need more training, and that even though there's no money for training, we've got to figure out a way for these folks to get more training. And then they created their own wish list for clinical supervision. All right, the findings, quickly. Finding 1, the participants had familial and personal traumatic experiences that influenced their interest in the helping profession. Many grew up with family members who were combat veterans and saw the effects of war trauma on them. They did not decide to treat combat veterans out of a need to master their own trauma. Instead, they felt comfortable and familiar with military culture and veteran issues. They were very clear, all of them, in the interviews that they chose to treat and to come to the VA because they have a familiarity with that culture. And not one participant said that when they helped a veteran work through their trauma and integrate it, did it help them with a family member or with their own traumatic history. Not one. Which was a very interesting finding for me because I was truly expecting the opposite.
Well, I think we've been kind of, our theory, and I think a lot of clinicians that don't work in military settings, it's an easy way for them to make assumptions about the people that do, and people that do things they couldn't do, say, oh, it's just an attempt at mastery, which I don't think is what Freud meant at all. And I think it's an important thing that you're pointing out. This is not just an attempt at mastery. It's much more complicated.
Exactly. Thank you, Dennis. Finding number 2, from the participants' experiences, it became apparent that vicarious traumatization is complex and varied. Many stated that they have been overwhelmed, though others said no when clearly they were. Being overwhelmed occurs by levels of awareness that varies. This was a fascinating finding for me. I always thought you either had it or you don't. And in terms of researching and seeing their experiences, many of them were completely overwhelmed, but said, but I don't have vicarious traumatization. I have dreams that wake me up at night, and yeah, I take it home, and I do this and I do that. But no, I don't have vicarious traumatization. And that was very, very interesting. And I remember in one of the interviews I had asked one of the participants that said that, so, what would that mean for you if you have vicarious traumatization? And he said it would mean that I'm damaged. So, yeah, so it's even among therapists, the awareness and what that term actually means varies. So it isn't an either or. As anything in life, it's very complex, and it's certainly complex with how it varies from therapist to therapist. So finding number 3. Participants reported they do not follow the 12-session protocol for the PTSD evidence-based psychotherapies because they typically ameliorate trauma symptoms only. They believe in having veterans integrate and master their combat trauma by developing and creating a trauma narrative over time that they may or may not include EBPs with.
Rule breakers.
And out of 17, there was only one that didn't do it. All the others broke the rules, quote unquote. But all the others did, which was amazing. They were very passionate about going where the client, or where the veteran needs to go. And that, you know, basically when I close the door, what occurs between me and that veteran is between me and that veteran. And I'll put the note in and I'll do what I need to do. But I'm the one in charge when that door closes, in the sense of how I'm going to treat this veteran, and the VA can stay out of the room. It was very, very interesting. Finding number 4. For many participants, directly providing combat treatment as a trauma therapist can result in developing more compassion, empathy, humility, knowledge, and healthier professional boundaries. And this surprised me. This was a very, very positive finding, and this really, truly enriched their lives. All of them said something along that line, and how it strengthened them and their compassion and all those different pieces of themselves, human nature and so on. They did not continue to become jaded. I was very surprised by that finding. And then the last finding is number 5. Participants were clear about what works and what does not work in terms of developing a formal program of clinical support, and including case supervision and consultation. Again, I've already discussed that, but so those were the 5 findings. So here's the core of my theory. Bobbie put it into 5 statements. I put it into a quick narrative. So this is what, according to the research I did, this is how my theory came together. The idea behind grounded theory is to take all of this information, all of this phenomenon, and try to make sense of it and create a story using their experiences. Individuals come into this work through various routes and ways, including personal traumatic experiences they may or may not have realized before, and family members who are veterans. There is more to this phenomenon of choosing to work with combat veterans than reworking their personal and familial trauma. Identifications are at work that make people feel more comfortable with veteran stories and issues. This is what enables them to sit with and listen to their traumatic stories. Practically every participant has reported some degree of vicarious traumatization. Several participants did not realize until the interviewing process of the study that they had experienced it. Vicarious traumatization experiences and one's awareness of them are highly variable. Even though clinicians hear and treat horrific traumatic stories, most have experienced vicarious resilience through the therapeutic process and have developed more humility, wisdom, compassion, and healthier professional boundaries. Finally, these clinicians find a way to do solid clinical trauma work within the limitations imposed by the current VA system at their facility. If there is one wish that dominated for them, it is to have real, frank clinical support and supervision where they can genuinely discuss their feelings and experiences treating combat veterans. And that's it.
Well, once again, if we could use the chat feature or the question and answer feature if you have any questions for Mike. And I know personally, Mike was the first student that ever took me up on this, that my thing is that that a central approach to studying trauma should be studying clinicians that are effective. And I think this has been looked at from every which way except talking to clinicians who are considered effective. And this is the first step in that direction, because I do think it's a missing piece in the literature.
When I actually conceived of the study, I did a massive review of the literature, and I only found one very small qualitative study, and it was, like I said, very, very small. I think it was 4 or 5 participants. It was mainly case studies. So at that time, there was hardly anything really written in the literature on this as well. Derek Estrada, I know Derek. Hey, Derek. All right, it says, Derek Warrior, just wanted to say that you are missed by many of us at the, oh gosh, thanks. That's embarrassing, but thank you, I miss you too.
They're stalking you, Mike.
Thank you, Derek. So, so my research really tried to fill a hole within the literature. There's so much that's been done on the experiences of OAF, OND veterans and PTSD, but hardly anything from the perspective of the therapist.
Mm-hmm. Bobbie, what's your take on, as you sit back and listen to Mike's study a couple years later?
My own personal response is that it is extremely hard to sit session after session listening to the soldiers. You do have a ton of countertransference that pops in there, and you do carry it home. And without somebody to process that with, and I think ICSW consultation provided that for me for the last few years that I was working with the military, using the case studies that I used with the different soldiers, it really helped to be able to process and take it in and understand what I'm listening to in a different way. I think a lot of the support is needed, not only just with the VA, but the support for the active duty, and as well as the civilian therapists that sit with the soldiers. We don't have that support. It's get in there, see the soldier, see the next soldier, see the next soldier, go home, come back and do it again. You don't have time really to even barely write your notes. So you don't get time to process, except maybe once a month, kind of like you talked, Mike, with the VA. You get a staffing, and that's not the time to bring up that you're having any trouble. So a lot of people have a hard time with some of this. I mean, they come to you with some very raw material that they don't feel like they can take to their command. They don't feel like they can take anywhere but to that therapist, if they feel comfortable telling the therapist. And then you have to be able to hold that for them and contain it. It's not an easy task.
Exactly, Bobbie, exactly.
Any other clinicians on the line that want to comment or have thoughts about Bobbie or Mike's work? I guess you stunned everybody. Can't even get Mike to say anything.
Which Mike?
Mike can't.
Sorry.
I'm trying to goad him into saying something. Well,
Mike, did you find that the question towards them about, trying to think of how you phrased it, where they were asked to talk about ways that they could improve that supervision, Did you find that the experience that they talked about was more of what they needed versus what they think everybody needed?
You know, that's a great question, and in terms of their answer, it was both.
It was both. Okay.
Yeah, it was both. Many of them talked about, in general, about, you know, having somebody who leads the group who is not judgmental, who's able to hold that space and that place of who feels comfortable with therapists getting emotional about their work and not judging them and holding that space, making it a safe place, a safe environment for that to happen. And then others, once they talked about in generalities, really talked about what they need specifically for themselves. Many of them discussed the need individually to have a place to go where they can just walk out of their office and go to a solitary place where they can just kind of close the door and just kind of be alone and just kind of get out of the room, because so much of the energy, quote unquote, sticks in there, and they just need a place to just kind of symbolically cleanse themselves. And others talked about other things that they needed as well. Some talked about, you know, it'd be wonderful if some really got out there about, you know, bringing in massage therapists and so on and so forth, because of how they hold so much of what they hear physically within their bodies, et cetera, et cetera. So, yeah, I would say both.
That's interesting. Blanchfield put that in place. They had a room you could go to that was like a meditation room. They would do things like send the providers off for, you know, a weekend. They would do different things like that, and the majority of the therapists wouldn't use it.
Oh, how interesting. How interesting. Wow.
And they wound up shutting that program down because it wasn't being utilized.
Were people afraid they'd be noticed using it? You know,
that's what my belief was, that people would think that they weren't handling it because they were seen walking in that private room, that kind of thing. I don't know. I also think it had to do with you didn't have time with the caseloads that we had. You don't have time to go use it.
Well, it's certainly, you know, how do you establish a culture, you know, within your clinic setting that's going to, you know, sustain deep clinical work and sustain your therapists that are doing the deep clinical work. And it's kind of disturbing stories the two of you are telling. No wonder you guys were so happy to get to ICSW to be able to talk for a change. I thought you just didn't want to shut up. You know, you just didn't want to talk too much. So no one was listening.
I'll be glad to walk next month. Yes.
Well, if we don't get any questions quick, we're gonna wind down for tonight. Last chance. So there we have it. Two fresh pieces of research, psychoanalytically inspired, and a foundation in psychoanalysis, and clearly using psychoanalytic concepts. And again, a kind of unique thing we do at ICSW, which is, you know, psychoanalytically, what I would call psychoanalytically informed qualitative research, which is pretty unique. So again, thanks for joining us. We will be posting the PowerPoints and the recordings on the website at APSA, the Service Members Veterans Initiative website, for should you want to use them in a class or future reference. They're there. There will be a recording of the night as well as the PowerPoints. And again, thank you for joining us. I want to thank Mike and Bobbie for taking time out to join us.
Thank you, and thanks for letting me present. And Derek, take care of yourself. Good to hear from you.
Okay. Good night, all, and keep posted for our next installment. Bye now.
Thanks. Good night, everybody.
Okay, good night.
Thank you. Good night.